Mr. Chairman, Congress President, honored guests and members of the ESNT, I take the greatest pleasure to welcome you to our 11th Transplantation Congress. The credit goes to the organizing company ICOM and the great support of the industrial organization. My deepest wishes to attend distinguished Congress with outstanding scientific and social aspects and a lot of memorable moments. The organizers shall always be around to take care of your country. As such, I introduce Professor Tariq Baz, ESNT President, to say his word.
بسم الله الرحمن الرحيم. بعد الحمد لله والصلاة والسلام على رسول الله. I'd like to welcome everybody to the ESNT's 11th Transplantation Congress. I'd also like to heartily welcome our guests, Professor Campistol from Barcelona, and for the first time we have the honor to meet and to welcome Professor Lina Zakharova from Moscow, President of the Russian Society. I have great pleasure being here today, and thanks have to go to Professor Maher Fouad, who's been the propeller of transplantation through this activity over the last 10 years, and it has been growing. Hopefully next year that we will be addressing cadaveric transplantation in Egypt. My special heartily thanks go to my good friend Dr. Amr Singh, who is the ESNT Congress coordinator, for organizing such a wonderful meeting together with his associates, the ICOM company and the pharmaceutical companies as well. I'd like to say a few words about the ESNT's activity that has been growing over the last few years due to the activity of various boards, and it's evolving in a wonderful thing the last 2 years. We have been doing a lot of education efforts in our society to help our colleagues who are living in remote areas through doing the education program every 3 months at our headquarters. We supply accommodation for about 45 doctors coming from all over Egypt from remote areas. And then we expanded our thoughts into the outreach program, which has been successful. Over the last year, we have managed to do one in the Minya Governorate, and last month we've been to Sohag, which is in Upper Egypt, educating doctors, nurses, having surgeons doing arteriovenous fistula, talking to patients, addressing cases, and even we did good kidney activity over there. It was very, very rewarding. Hence, we had a new idea and to start to outreach out of the boundaries and borders of Egypt. And now next month, I'm glad to announce that together with my good colleagues, Professor Gamal Saadi, President-elect, and Professor Hani Hafiz, who is the Vice President, Professor Walid Masoud, and Professor Hassan Shaisha, we're going to outreach to Africa. We're going to Sudan and Ethiopia. We need to help these countries. We have links and ties between them, historical and geographical. We need to be there to show them that we are there for them. As such, I'd like to thank you all, and I hope you have a very interesting and good meeting. Thank you.
Professor Maher Fouad, Congress President, will give his speech.
It is to my pleasure to welcome you all and announce the start of the 11th Transplant Update meeting organized by the Egyptian Society of Nephrology and Transplantation. It is really a golden chance to all of us to discuss the recent literatures and to realize our local problems, trying to solve it if possible. We are at the beginning of a cadaveric transplantation that will create a great revolution in our transplant practice. as a member of the ISN Guidelines Committee and the Egyptian Society of Hypertension Guidelines, I have to highlight the recent guidelines in this expanding field of transplantation. I call them welcome our guests, Professor Joseph Campistol and Professor Lina, to attend our meeting. And I have to express my sincere gratitude to Dr. Ammar Hussein for his tremendous efforts. I also thank all drug companies that have their participation and support, namely Novartis, Roche, Amgen, Sanofi, Pfizer, Janssen Select, Sun Medical, and the Egyptian Group. And at last, I have to thank ICOM, the organizing company, for all their efforts. Thank you very much, and welcome for all.
Professor Gamal Saadi, President-elect, now will give his word.
Bismillah ar-Rahman ar-Rahim. I would like to congratulate you, all of you, for attending this 11th transplantation meeting, and on behalf of the ESNT board, Nazmi and board of the board, we give all our thanks to Professor Nahar for his very sincere and enthusiastic coverage for the transplantation branch. He is always performing the best scientific approach and links to all these important institutes, and he's doing a great effort, and he was helped by Professor Ammar Hussein, who is doing a great job. Actually, we are very honored, as Professor Tar and Professor Nahar mentioned, that we are having attendance of two distinguished schools of nephrology from the Russian school, represented by Professor Elena Zakharova, welcome, and the Spanish school, represented by our dear friend Professor Joseph Campistol, welcome. And we are looking forward not for only attendance, we are looking forward, Professor Elena and Professor Joseph, for mutual work and collaboration for the three societies, not only attending meetings. We want to do a strategies for further cooperation. I would like to announce the concept of the establishment of the Egyptian Society of Organ Transplantation, and we have the first annual meeting in September 2014, and all of the transplanters in the Society of Nephrology are requested to attend and to do their membership in this society, because it's of paramount importance to have our representation, as a nephrology renal transplantation to be fully represented. I would like to also announce that we are starting the brain death awareness committee in the Ministry of Health, and we perform the committee of diagnosing brain death as a central activity, which will start in Aslan University and in the military hospitals. And we made already 2 awareness meetings, and we'll have the next awareness meeting on the 30th of this month in New Aslan Teaching Hospital, and those who are interested will be invited to attend. And this is preparing to start the cadaveric program. I would like to congratulate you all once more, and let me congratulate you and all the Egyptians with the excellent results we achieved yesterday and the day before in performing our first voting for the new establishment, and I think we'll have a great progress. So let me greet all the Egyptians for this great result. Thank you very much. Thank you.
Welcome all of you at this marvelous place in the heart of Cairo, beside River Nile, and let's enjoy having science. Thank you.
I would like to make some announcements. First, we wrote the World Kidney Day today, this year will be addressing the geriatric people, And I think we will have the opportunity during the speeches in these 2 days to address the transplantation in old people, whether old for old is the principle, or we can, and what is the prognosis of making transplantation in elderly population. I would like also to express the gratitude and the honor to have Professor Campistol and Professor Zakharova here. And I will not leave Professor Campistol except when I present that we have the vision of the Spanish society, that now you have 50,000 patients of CKD stage 5. Exactly the same number is present in Egypt. We have also 50,000 CKD stage 5. But the difference is that you are transplanting 50% of these. I mean, you have 25,000 transplant a year, but we only have 1,800 transplant a year. So our vision is to become like you, to increase the percentage of transplant patients from less than 5% to be not 50% like you, but at least go in this way. And I think going in the cadaveric transplantation will be one of the important methods to reach this target. Finally, I would express my honor to be in the 11th ESNT transplant congress, which is now becoming one of the landmarks of the nephrology society. I mean, every year we are waiting for this congress to see what's new, what's hot, what are the advances in the field of transplantation, and it is becoming exactly like the annual congress of the Egyptian Society of Nephrology, one of the milestones that could not be missed. Thank you very much.
We shall start the first session. It is a plenary session, and we welcome Professor Joseph Campistol to be our speaker. The title of his talk, Minimizing Late Graft Loss. Professor Joseph, welcome.
So, good morning to everybody. Thank you very much, Professor Mayer, Professor Kamal, Professor Tarek, and Professor Hani, for your work, for your introduction. It's for me a great pleasure to come back to Cairo, to come back to Egypt. We have a really good friends in this country, and it's really for me a great pleasure to be your 11th meeting of the Egyptian Society of Nephrology and Transplantation. Thank you very much also, Dr. Hani, for your words about our Spanish or Catalan Society of Nephrology and Transplantation. And absolutely, we are open really to collaborate and to help you in any purpose, trying to increase activity and trying to increase also graft and patient survival of your patients. So thank you very much for the kind invitation, and thank you very much for your words about our society and about our work. In the next 30-35 minutes, I try to go and I'd like to discuss with you what we can do really to minimize late graft loss in kidney transplantation. And let me try to start and to introduce one of the things that we know very well. In the last 10, 15 years, with the introduction of the new immunosuppressive drugs, we did a very good job to control the incidence of acute rejection. And I am sure here in Egypt, in Alexandria, Mansoura, Cairo, the incidence of acute rejection these days are low, maybe 10, 15%, no higher than 15%. But the same way that we really control and prevent acute rejection, we progressively increase 1 year graft survival. So I think that we did a quite good job on the control, on the prevention of acute rejection, and also in the short-term graft and patient survival. But as you know, we have a problem in long-term follow-up. If we review our data, that's data from US, but could be extrapolated to Europe, to Spain, and I'm sure to Egypt. In the last 10, 15 years, we didn't observe a significant improvement in long-term follow-up. Using more recent data, as you can see here, using the American Transplant Registry, you can see here that there is a plateau in the long-term graft survival. So I think that we did a quite good job to prevent acute rejection, a quite good job at 1 year graft and patient survival, but we have really a problem considering long-term follow-up. And I am sure that this problem is in States, in America, it's in Europe, and I am quite sure it's also here in Egypt. And if we consider why we are not able to extend graft and patient survival in long-term follow-up, and as you know, there are two main reasons. One, it's death with a functional graft, cardiovascular and cancer, and the other important reason is the development of IFTA, chronic allograft nephropathy, progressive graft loss, progressive interstitial fibrosis, and tumor atrophy. And approximately 35 to 40% of our patients will go back to dialysis secondary to chronic allograft nephropathy, to IFTA, multifactor etiology, immunological, non-immunological, senescence, recurrent, different things. But the main problem, we lost a lot of graft after 9, 10, 12 years. And the second important reason is the death with a functional graft. Death, cardiovascular, death, cancer. Exactly as the general population, but maybe in a more aggressive way, in a more anticipated way. So I think that we have a problem really in long-term follow-up, in long-term results related with the death of our patients and related with the development of chronic allograft nephropathy. And if we consider the follow-up of these two problems in the long terms, CAN, IFTA, and death, as you can see here, using Australian and New Zealand registry, the problem was the same last year than 10 years ago. So we have a problem, and we are not able, at least today, to solve these problems, to avoid, to delay graft loss, and to delay the death of our patients. And very important, don't forget the death of our patients. That's a quite important problem. Cardiovascular disease, cardiovascular death, and cancer, and at least in part related with the drugs that we use, related with the iatrogenicity of the immunosuppressive drugs that we use. It's true that these two main reasons, cancer and cardiovascular diseases, are the same as the general population. But as I mentioned before, in a more aggressive way, in an anticipated way. If the general populations have cancer when they are 55, 60, 65, our patients develop cancer when they are 40, 45. If the general society develop a myocardial infarction at 55, 60, our patients are 45 or 50 years old. So we have a problem in both, in cardiovascular diseases and also in cancer. And I consider that at least in part, these two main reasons of death are really related with the drugs, with immunosuppressive drugs that we use, that are good to prevent immunological events, but could be detrimental, could be negative on the development of cancer and also on the development of cardiovascular diseases. But although with this not so good scenario, I think it's important to put up to the table that renal and kidney transplantation is the main treatment for end-stage renal disease. And I think that must be a target, that must be a challenge for all of us. As Dr. Hani said, I think it's critical to press and to push as strong as we could most of our patients for kidney transplantation. It's absolutely clear that kidney transplantation is the best therapeutical option for end-stage renal disease, for the best quality of life, for the less economical budget, and also for our longest patient survival. So I think that we need to work hard really to move from dialysis to transplantation, but also we need to work hard trying to extend graft and patient survival. So if we consider which are the most important limiting factors which don't allow us to increase graft and patient survival, I think that there are three main reasons. The first reason is the limit transplant activity, and in many cases the use of expanded criteria donors. I will go later on this point, but I think it's also an important point to know, to learn, and to consider as a limiting factor in long-term graft and patient survival. The second important thing is the chronic allograft damage. Different reasons, could be immunological, could be CNI toxicity, could be senescence, could be recurrent. Chronic allograft damage is a very important heterogeneous disease that we need to work hard if we want to improve and to extend graft and patient survival. And finally, the third important reason, as I mentioned, is accelerated death. Cancer and cardiovascular diseases. So if we put together, I think it's crucial first to increase transplant activity, second to prevent chronic allograft damage in all etiological factors, and third, very important, try to delay the accelerated death, try to delay cancer and also cardiovascular diseases in our patients. So putting in the table and considering all these factors, I have 4 different groups of proposals trying to increase, trying to extend graft and patient survival in long-term follow-up. The first group of proposals is about renal transplant activity. The second group of proposals is about organ allocation. That's a quite important thing that I think we need to consider and we need to work. The third point, which is in our hand, quite easy, but we need to learn, we need to work hard. It's about immunosuppression and immunosuppressive therapy of our patients. And finally, the fourth important thing, working all together, working as a team, is medical management of transplant patients. And that's a quite important thing. I know it's different topics, transplant activity, organ allocation, immunosuppressive, and also medical management of transplant patients. And I think it's absolutely necessary in the transplant scenario to work as a team. We need, as nephrologists, to collaborate with surgeons. We need to collaborate with the cardiovascular experts. We need to collaborate with radiologists, with immunologists. Transplant work is a transplant team. If we don't work together, it will be very difficult really to improve long-term graft and patient survival. So I consider that these 4 groups of proposals could be quite important and quite interesting to increase, to extend graft and patient survival. Let me try to go on detail on these 4 blocks of proposals, and let me try to discuss with you about transplant activity, organ allocation, immunosuppression, and medical management. The first important thing is about transplant activity. And I think it's absolutely necessary that we need to increase transplant activity. Dr. Kamal, Dr. Hani make a very important comment. Transplantation, it's the best therapeutical option for our patients. So we need to work hard to increase transplant activity. Although we use cadaveric disease donor, although we use expanded criteria donors, using any kind of donors, optimal donors, DCD, expanded criteria donors, the results are always better than dialysis. So that's our duty, and we need to work hard on these proposals. And that's a very well-known study from Dr. Akilolo Ojo showing that just after 3 to 6 months of transplantation, results of renal transplantation are better than dialysis. If we use an optimal donor just after 3 months, patient survival is better than dialysis. If we use a marginal or expanded criteria donors after 6 months, patient survival is better than dialysis. So I think that we need to work hard really to propose transplant activity as the best option for our patients. Let me show you, as Dr. Hani mentioned, the situation in Spain. Spain is not so different than Egypt, and I am absolutely sure that you, working as a country, working as a team, could do exactly the same progress as we do in Spain. That's the follow-up of transplant activity in Spain in the last 15 years. And as you can see here, there is a progressively increase on transplant activity. Most of the donors are cadaveric donor, and every year, also last year, 2013, we also observed a slight increase on transplant activity. So working as a country, as a society, as a team, we have really the chance to increase transplant activity and to progressively move our patients from dialysis to transplantation. Although we do the things quite good, we have approximately 4,000 patients on the waiting list. So we also, Spain, have a challenge really to increase transplant activity, to increase graft and patient survival, and also to move our resources from dialysis to transplantation. But as Dr. Hani mentioned, our situation is not so bad. We have approximately 50,000 of patients with type 5 CKD, and approximately 50 of them are on dialysis, and 50 of them as a functional graft. But it's clear our objective is progressively increase these numbers, increase this percentage, and move our patients from dialysis to transplantation. And again, Spain did a quite good job on transplantation. I am absolutely sure that also your society, your country, working together with the authorities, with coordination, with surgeons, with nephrologists, with immunologists, you can also progressively increase transplant activities. I am sure that you have a lot of cadaveric disease donors, and you progressively improve your situation on cadaveric activity. Remember the term and the point that transplantation, although using expanded criteria donors, it's always better than renal transplantation. The second important point, trying to increase transplant activity, it's about living transplantation. And I think there is one very important message about living transplantation. Living transplantation is the best option, and it's always better than disease donor. So we need to offer to all our patients the option of a living transplantation. And using living transplantation, we can do preemptive. We save the kidney for long term, and then we can dedicate the limited resources of cadaveric to patients without a living donor. So I think it's absolutely clear that living must be the first option to our patients, with a good results, with a great results in terms of graft and patient survival. Here you can see the situation of Spain 4 years ago. Spain was not a very good country on living transplantation. Why we were not a good country? Because we have a lot of cadaveric, a lot of disease donors. But in the last 5 to 10 years, the number of brain death, the number of DCD progressively decreased. And I want to show you the progressively increase of living transplant activity in Spain in the last 5 years. And last year, we did approximately 500 of living transplant activity. These days, living transplant activity represents around 20% of the whole number of transplant in Spain, and in Catalonia, in our region, it's from 35 to 50% of our activity. So I think that we do a good job on living transplantation, but I think that always could be improved, and always we need to offer to our patients the option of a living transplantation, of a living donor as the first and the best option to increase activity and to solve end-stage renal disease situation. And third, and probably more important and related with living transplantation, is preemptive renal transplantation. I think it's absolutely clear from all the studies that when we do preemptive transplantation, results are much and significantly better. So I think that we, as a general nephrologist, as a physicians who take care of chronic glomerulonephritis, polycystic kidney disease, chronic diabetic nephropathy, different kind of things, I think that we need to offer to our patients the option of a preemptive kidney transplantation. When they are with a GFR of 20, 50, 10 mils per minute, I think that the best option, instead to go to dialysis and then do a late renal transplantation, we need to do preemptive renal transplantation with a significant better graft and patient results. And that's the best option. It's the best option for our patient, but it's also the best option for the system. We save money, we save kidneys, and we save all the things. So I think we need to work hard again with a team in collaboration with the clinical nephrologist, with people who take care of pre-dialysis, really trying to offer to our patients the option of a preemptive kidney transplantation. The second point that I want to go with you is about organ allocation. I think that there are 3 important points that we need to consider, and I am quite sure that will improve long-term results if we do a good organ allocation. The first one is about reduced cold ischemia time. I'm talking mainly about disease donor, I'm talking about cadaveric donor. All the studies show that when there is a short cold ischemia time, lower than 15, 16 hours, results are much better. Not only short-term results, long-term results. And that's very cheap to reduce cold ischemia time. It's just a problem of dedication, it's just a problem of organization. All studies show when cold ischemia time is lower than 15 hours, long-term, not short-term, long-term results are much better. Lower DGF, lower acute rejection, and better graft survival, better renal function. So I think that we need to work hard really to decrease cold ischemia time when we do a disease donor. That's a quite important point. The second important thing when we talk about organ allocation, it's about HLA, gender, and BMI matching. That's a quite important thing, and especially 2 important points. One, it's about immunological compatibility, HLA matching between donors and recipients. And the second important comment, it's about all for all. Let me try to go on detail about these 2 points. I think all the studies show when there is a better matching between donor and recipients, results are better. So I think that we need to also, again, work hard in collaboration with the immunologists, trying to obtain the best matching between donor and recipient, trying to improve long-term results. That's an immunological work, also again as a teamwork in collaboration, trying to offer the best kidney for the best recipient. It's clear if there is a good matching, results are better. If there is a lower matching, results are not so good. So I think that we need to work hard at least to obtain an average matching between donor and recipient. The second important point about matching is about age, also about BMA, but let me mention about age. And when we talk about age, I am talking mainly about all for all. When we have a marginal donor, 60, 65, 70 years old kidney, we cannot offer this kidney to a young patient. Young patients need good kidneys, so these all or marginal donors could be offered to our patients. We have a long list, the waiting list of patients with 60, 65, 70 years old, and I think it's perfect for them really to receive a kidney, a marginal kidney, a kidney with 60, 65, 70 years old, which will be perfect for them and will really save and ensure a good graft and patient survival. So remember that when we do a matching, consider age and consider all for all as a good strategy in long-term graft and patient survival. The third point about organ allocation is to improve graft viability. And in this way, different perfusion liquids, different perfusion machines could be helped, especially if we talk about marginal donors or especially if we talk about non-herbitic donors. I think in patients with marginal donors, we need to consider low cold ischemia. We need to consider also to use the perfusion machines as the way to improve the graft viability. And finally, another important thing is baseline biopsies to improve graft evaluation. We need to know which kind of kidneys are we transplant. That's a good kidney, that's not so good. So I think graft biopsies, baseline graft biopsies would be quite important really to know the viability, the conditions of these kidneys, and then to decide in which patients we can use these kidneys with 5-10% of glomerular sclerosis or mild interstitial fibrosis or tubular atrophy. So I suggest really in marginal donors to use a baseline graft biopsy to take the decision. The third point that I want to comment with you is about immunosuppression. And immunosuppression is in our head, and it's something that we can decide taking care of conditions, patients, and also medical and historical background. And when we talk about immunosuppression, I think there are two important points. The first one is individualized immunosuppressive therapy. Patients are different, donors are different, grafts are different. We cannot give the same immunosuppressive therapy to all our patients. Patients need a specific immunosuppressive therapy if they are high immunological risk, if they receive a marginal donor, if they are low immunological risk. So I think it's crucial and important to divide our patients with different subgroup of patients, considering different factors related with the medical background, related with the immunological background, related with the graft conditions. And in our unit, we divided our patients in 5 different groups, and then we give and we administer a specific immunosuppressive therapy for all these 5 groups. We consider a standard renal transplantation as first kidney transplantation, donor from 20 to 50, 55, same age of the donor and same age of the recipients. Patients with a high immunological risk, second, third, high immunized patients. These patients need a specific therapy and a strong immunosuppressive therapy. Pediatric patients need also specific therapy. Patients with expanded criteria donors, patients with a special nephrological risk needs to minimize CNI or to avoid CNI, and also I think patients with hepatitis C needs a specific therapy. So I think patients are different, transplants are different, and we cannot give the same therapy to all our patients. We need to individualize immunosuppressive therapy considering the patients, the medical background, the immunological background, and also the graft. And also, very important, we need to consider that the immunosuppressive therapy is a dynamic process. It's different today, it's different in the first month, in the first 3 months, than 2 years later. If we maintain the same strong immunosuppressive therapy that could be good to prevent immunological damage, that could be good to prevent acute rejection. But unfortunately, our patient will develop cardiovascular diseases or our patient will develop a cancer. So it's absolutely crucial to individualize immunosuppressive therapy and also to consider immunosuppressive therapy a dynamic process which changes during time. We need to prevent immunological damage at the beginning, but on the long term, we need to prevent toxicity. Toxicity of the immunosuppressive drugs on the terms of cardiovascular diseases and also on the terms of cancer. If we don't consider immunosuppressive therapy a dynamic process, we'll have problems on the long-term follow-up. The second important point when we talk about immunosuppressive or immunosuppression, it's about immunological monitoring. I think that today we learned a lot about that. We did a good progress to improve the immunological monitoring, but we need to apply and we need to use. On these terms, I think there are 3 different technologies that probably need to introduce in our units on a different way, which could help us to take decisions to minimize immunosuppression or to increase immunosuppressive therapy. I am talking about ELISpot, I am talking about PSA, or I am talking about Luminance. So I think it's crucial to use in a good way technology to improve immunological monitoring and to know if there is a problem, if there is a lower immunosuppressive therapy or there is a strong immunosuppressive therapy. It's the only way really to take the decisions in a proper way and to take the decisions based on evidence, based on scientific point of view. The third point when we talk about immunosuppression, it's about immunosuppressive therapy. I think that we did a good progress to prevent acute rejection, but I think there are other important things that could be used in the clinical practice which really will save, grab, and will save life on our patients. When we talk about immunosuppressive therapy, I think there are different options and different strategies that could be important. First, to prevent immunological damage. Using induction therapy in patients that need induction therapy, I think it's important. Maybe not all our patients need induction therapy because induction therapy has also long-term infections and cancer problems. But maybe in some patients that would be good to prevent immunological damage, immunological insult, to prevent acute rejection. Different therapies with desensitization. Patients with a high immunological risk could be transplanted using different strategies with plasma change, with immunoabsorption, with the use of rituximab. In long term, the use of non-nephrotoxic therapies with mTOR inhibitors, with MPA. That could be helpful really to prevent CNI toxicity, and not only CNI toxicity, also cardiovascular and cancer conditions. Also, very important when we talk about steroids, trying to avoid or try to eliminate steroids in the long-term follow-up. I think steroids would be a quite important drug for short-term, are very good anti-inflammatory drugs, but they are not very good immunosuppressive drugs. And as you know, steroids would have a detrimental role in long-term. Not only on the aesthetic way, also in the cardiovascular way, hypertension, hyperlipidemia, hyperglycemia, on the arteriosclerosis. So it's crucial in most of our patients that we can do to avoid, to eliminate, to withdraw steroids in the long-term follow-up. Also, different therapies that could favor immunotolerance. We know very well that the use of mTOR in a proper way could help to immunotolerance acquisition. I think that's quite normal today. We know the increase on Tregs, the use of mTOR could be helpful on the long term to minimize immunosuppressive therapy and to avoid acute rejection. And 2 recent drugs. One, to block humoral rejection, humoral component with the use of rituximab or the use of bortezomib, and also maybe in the next future the use of anti-C5 and the complement C5, the eculizumab, which could be quite interesting to treat and to prevent humoral rejection. We are now in a prospective trial using eculizumab in high immunological risk patients, and the drug is absolutely extraordinary. The use of the drug really reversed the acute humoral rejection with a very good follow-up, with a completely normal renal function without proteinuria. So I think that in the next future, the use of this anti-C5 agent, this monoclonal antibody, this eculizumab, could be quite helpful in patients with high immunological risk, both to prevent and also to treat humoral rejection. And finally, let me just to finish about the medical management of transplant patients. Don't forget that our patients, 50% of them, 45% of them, will die with cardiovascular diseases or will die with cancer. So I think it's crucial, really, to do a good medical management of our patients. And when we talk about medical management, there are two parts. One, it's graft monitoring. And when we talk about graft monitoring, I think it's crucial, and I think it's our duty to do a strict follow-up of our patients. A strict follow-up in the terms of renal function, serum creatinine, creatinine clearance, proteinuria, blood pressure. It's absolutely necessary to do a strict follow-up of our patients, not only in the short follow-up, also in the long-term follow-up, to avoid non-compliance, to avoid the development of proteinuria, to avoid under-immunosuppression. The strict follow-up is absolutely necessary, the control of proteinuria and the control of hypertension. Also, renal ultrasound will be useful every year, every 2 years, first to know and to detect how are the graft function, and also to anticipate on the detection of small tumors of the graft. And finally, I strongly recommend protocol renal biopsies. We start with protocol renal biopsies 5 years ago, and we are absolutely happy about the use of protocol renal biopsies. We do 2 protocol biopsies, 3 and 12 months, and they really help us to take the decision. You feel much more comfortable with histology, to know that everything is fine, to know that there is no transplant glomerulopathy, to know that there is no cellular infiltrate, to know that there is no glomerular problem. So I strongly recommend to do a strict follow-up of your patients, a strict follow-up of the graft, and to introduce in our units protocol renal biopsies to monitor, to follow your patients. The second important point when we talk about medical management is about cardiovascular diseases. Don't forget that our patients came from end-stage renal disease, came from dialysis with a lot and high prevalence of cardiovascular factors. So I think it's absolutely necessary to do a strict control of all cardiovascular risk factors. Blood pressure, smoking, lipids, glucose, all the things must be controlled in a perfect way. Don't forget the negative role of new onset diabetes mellitus. Diabetes has a negative role on graft survival and on patient survival. So we need to be strong on the treatment, on the prevention of all graft survivals, including lipids, diabetes, hypertension, smoking, etc. Tobacco is devastating. I don't know how prevalent is tobacco in your patients. In Spain, around 15% of transplant patients are still smoking. I think it's very bad in general, but it's also very bad for our patients. And also, alcohol consumption must be limited to all our patients. And finally, very important, the use of different drugs, the use of different cardiovascular drugs that are absolutely mandatory for our patients. Why we don't use low doses of aspirin in our patients? Why we don't use low ACE or angiotensin II receptor blockers? Why we don't use universal statins in our patients? All these cardiovascular protecting drugs are absolutely necessary in a patient with a high cardiovascular risk factor, and it's something that we need to consider, we need to introduce in our practice, and we can do, and we need to do. The third point, when we talk about medical management, it's about cancer. Don't forget that we have a high incidence of cancer in an aggressive way, in anticipated way. So when we consider cancer, first, we need to consider our patients with a high risk of cancer, and we need to limit all external negative factors which could be quite important. Again, tobacco, alcohol, substitutive hormone, different things that could be negative for patients and especially in our population with high risk of cancer. Very important, routine screening, not very sophisticated, not very difficult, but maybe skin, maybe colon, maybe prostate, maybe abdominal ultrasound. Simple things that could help to early detect the presence of cancer, and then we can improve really long-term results and we can decrease mortality. Finally, it's absolutely clear that the use of mTOR inhibitors would be helpful to treat and to prevent cancer in our patients. So don't forget that cancer is an important, like cardiovascular disease, and we have different options. First, to prevent, second, to do early detection, and third, to improve long-term patient survival. And finally, the last thing that I want to comment is about opportunistic viral infection. That's a quite important thing. That's something that we need to learn and we need to improve. And I think today it's quite clear that different pharmacological prophylactics could be helpful to prevent CMV, helpful to prevent leukocytosis, and also helpful to prevent, in some patients, tuberculosis. So I think it's important. I am sure that here in Egypt it's a quite important point, try to work hard to prevent opportunistic infections in our patients. Also, to modulate immunosuppressive therapy. Don't forget that the strongest therapy associated with the highest incidence of infection. That's something that we need to learn and we need to know. Also, different antiviral treatment in different ways. Finally, again, the use of mTOR inhibitors, as you know, is associated with a low incidence of viral infections, mainly CMV and BK. Most of the studies show that the early use of mTOR is associated with a lower CMV, lower BK. So that's the 4 points when we talk about medical management that I think we need to consider if we want to improve graft and patient survival. How about the future? I think there are 3 general proposals about the future that will improve and will be in our hands. The first important point is personalized therapy. I am quite sure that with the genetic identification of donor recipients, we can do very individualized, very personalized immunosuppressive therapy, which will help clearly on graft and patient survival. In the meantime, we need to work with the tools that we have, but I am quite sure that in the next future, the genetic background, the genetic identification of patient and donor will help on these proposals. Second important point, biomarkers. Biomarkers are absolutely necessary. First, to know graft health, to know the health of the graft, and second, to know the immunological status. Today, we don't have good tools, although we need to use, but I am quite sure that in the next future, different biomarkers could give advice. How are the things going about the graft? How are the things going about the immunological status of our patients? Maybe in the next future, the use of co-stimulator blockers, belatacept, could be helpful. You know that belatacept is a good drug, although there is some logistic problems, but I think could be helpful to avoid all cardiovascular problems and also to improve graft function. And I guess that the drug will be in the market. And finally, the work with the immunotolerance and different proposals of immunotolerance will be helpful really to improve graft and patient survival. So just to finish, just to conclude, I think that a sustained improvement in long-term graft and patient survival is absolutely feasible, but a strict follow-up of recipients, a multidisciplinary approach of renal transplantation, including medical, nephrological, surgical, immunological, are absolutely necessary really to obtain and to improve graft and patient survival. So that's it. Shukran, and thank you very much for your attention.
Thank you, Professor Joseph, for this excellent talk. Any question from the floor?
Don't do personal or political questions, just silent.
Football question.
Football questions could be fine. But you know that we also in Spain have also a difficult political situation, so don't make the political and difficult questions in that way. Yes, please go ahead. There's a microphone? There's no microphone?
Could you move to a microphone, please?
No, microphone is there. Please, the microphone is coming.
Thanks very much for this wonderful lecture, but I need to ask, what protocol do you have to elicit patients at high risk of cancer, whether they have a dormant cancer before transplant or cancer or they develop cancer after transplantation? Do you have special steps in your protocol to identify the privilege of this cancer, likely or not?
Thank you very much for your comment and for your question. I think cancer is an important topic, but I think that today we have tools, really, first, to prevent cancer, and second, tools to prevent the recurrence of cancer. I think it's quite clear from all the studies, from all registries, and from prospective studies, that the proper use of mTOR inhibitors is associated with a lower incidence of cancer and a lower incidence of recurrence. We published several papers about cancer. We just published a paper on transplantation about 10 patients submitted to a kidney transplantation from a graft with a small tumor with a good follow-up, with an average of 3 years, without any sign of recurrence. So I think that to give individualized immunosuppressive therapy and the use of mTOR inhibitors could be very helpful to prevent the recurrence of cancer and also to prevent de novo use of cancer. Of course, we always need a waiting time. We always need a time from the treatment of cancer and to transplantation. The time could be 1, 2, 3 years, depending the aggressiveness of cancer, depending the type of cancer. But I think that with the use of mTOR and with a low immunosuppressive therapy, we can submit our patients to transplantation with a good follow-up. Don't forget that the risk of death on dialysis, I don't know here in Egypt, but in Spain, it's around 15% per year. So 15% of our patients, general, will die on dialysis. That's something that we always need to balance. But in summary, to modulate immunosuppressive therapy, to use mTOR inhibitors could be quite helpful to prevent cancer and to prevent the recurrence of cancer.
Thank you for the very nice presentation. I have two questions. You have an increased incidence, a rising incidence of liver transplant. All of them are related or not? Number one. And how to solve this problem? The increased living, all of them related. Number two, what you routinely treat HCV? We have a very big incidence of HCV in our dialysis patients, but they are candidates for transplant. Do you routinely treat HCV before transplant or not?
Thank you very much for your comments. I can tell you 100% of our liver transplantation in Spain are related. Related could be my wife, could be my father, could be, not my son, I don't like sons, I like grandfather or father, but not son. So all of them are related. Could be the spouse, could be the uncle, could be the sister-in-law, but all of them are related, or blood-related or emotive related. We never accept an unrelated living transplantation. And it's very spectacular how we increase living activity. In our unit that we do 150 transplants per year, 50%, 50% in the last 2 years were from living transplantation with a very good result. So we push very strong really on living transplantation, and we push very strong on preemptive kidney transplantation. Around 1/3 of our living transplantation are preemptive before they go to dialysis, before they have a fistula, before they go a peritoneal dialysis. So all of them are related, and I push and I encourage you very strong to increase living activity. About hepatitis C, I think we are very lucky in Spain, and now only less than 5% of our patients are positive for hepatitis C. I strongly recommend today to do a treatment before transplantation. You know that there are new drugs, not only interferon, not only ribavirin, also antiviral drugs with a good tolerance, with a good results, and I think you need to treat your patients before transplantation. Hepatitis C is a very bad friend on your route, so if you can't treat and you can't solve these problems before transplantation with the interferon, with the PEG, with the combination with ribavirin, with different antiviral, I think it's very important, because in the future there will be increase on viral load, there will be increase on liver damage, and there will be problems also of immunosuppression. So I strongly encourage you to treat your patients before transplantation.
Professor Campistol, you have been talking about the induction therapy using the monoclonal antibodies, and it's better to give it to patients at high immunological risk. I quite agree. But there is a current trend saying to use it at a larger spectrum without any fear. I would like you to talk about this because it's a kind of trend now. People are pushing to use induction for everybody.
I explain what I think and what we do in our unit. We have two options for induction, to use or not to use. And if we use, we have monoclonal or polyclonal. The first important message, polyclonal are stronger than monoclonal. So if you have a high immunological risk, don't use monoclonal, use polyclonal. 100% sure, 100% sure. Although there is some problems with infection that we can prevent with mTOR, you must be clear that polyclonal are stronger induction than monoclonal. To use monoclonal in the rest of the patients, it depends how rich you are. I can tell you what we do in our unit. 4 years ago, we used monoclonal in approximately 60-65% of our patients. These days, we're using 1/3 of our patients. As you know, we have a quite strong economical crisis. We have a lot of restrictions, and we cannot use monoclonal in all our patients. So, in patients without immunological risk, we don't use monoclonal, living or cadaveric. We do approximately 30% of our cadaveric, of our living, without monoclonal. First kidney transplantation, good compatibility, without any immunological risk, we don't use monoclonal. So if you are a rich country and you can use, that could be good for you. I don't think that's your situation. So what I recommend, to select your patients considering immunological risk. And very important, strong immunological risk, polyclonal. Mild, high, monoclonal, polyclonal. Mild, monoclonal, low immunological risk, no induction.
But you wouldn't recommend, by all means, giving polyclonal to patients who are not at high immunological risk, just to decrease the incidence of acute events.
The other option, I like very much polyclonals, and we use polyclonals in approximately 35-40% of our patients. And I think if we we give low doses of polyclonal, it's a very important role. We use 2 doses of campistol, 2 doses of ATG. The price is not so high, decrease a little bit acute rejection, and maybe also an important role on immunosuppression. So I am in favor to individualize immunosuppressive therapy, not to use 7 doses, exactly high doses in all the patients, to modulate considering immunological risk and considering also the quality of the graft. The other important thing for polyclonal is you don't need to use high doses of CNI from day 0. You can start maybe day 2, day 3, and start with low doses. So the use of polyclonal is not only to prevent active rejection, it's also to modulate immunosuppressive therapy and to give the option to obtain the best renal function. That's my concept.
Thank you.
Excuse me, does this also apply for the pediatric age group of patients?
Absolutely, 100%.
Excuse me, Professor Campistol, let me thank you first.
Don't say Professor, say Joseph.
Later on. Let me thank you for your very comprehensive and illustrative presentation, and you highlighted the importance of individualization. While sometimes in institutes we have randomization for specific protocols. How would this match together?
Thank you very much, Professor Gamal, for your very good question. Of course, if you are in a clinical trial, if you want to do science, if you want to know which is the best therapy, you need to do in a prospective way, and you need to do in a protocolized way. But when you finish the protocol, know which therapy is better, and then apply the therapy. That's something that we don't do in general. We do many trials. We have clear ideas, but with them we don't apply it to our patients. So I accept it. If you are doing a clinical trial, a prospective trial, you need to randomize your patients. But when you finish the study, 1 year, 2 years, analyze the results, have clear conclusions, and then apply the conclusions to our unit. That's my recommendation. And I think we need science, and we need to know which is the best therapy, because probably we don't know which is the best therapy for the beginning and for the long term. So of course, I am in favor to do trials, to randomize patients, but later on to take conclusions and to apply the conclusions.
Please, thank you. encouraged use of mTOR later on after transplant to release CNI toxicity. What about the fear of many reports of increased patient mortality from hyperlipidemia, cardiac and cerebral? There are many applications for that.
Don't believe. That's my word. Maybe today I'm very categorical. I sleep just a few hours, I am very categorical. Don't believe. I can tell you from my personal experience. We start using mTOR inhibitors, initially rapamycin, and these days more everolimus, in 1995. So it's close to 19 years from now. I have patients with 20 years on mTOR inhibitors on monotherapy with a very good follow-up. Of course, if you use mTOR as a rescue drug, if you use mTOR in your worst patient, you have a higher mortality. That's absolutely clear. And if you use the drug just as a rescue, or you use the drug in patients that you really don't know what to do, you are doing a random situation. So that's not proper. That's not good. I can tell you, if you use mTOR in a proper way, and I think that today we have clear ideas how to use mTOR. Low CNI, low mTOR, excellent results. I was discussing this morning with some of you. We introduced low mTORs in the unit with low CNI last year in 2013, and in these days, in approximately 85% of our new transplant patients are with low CNI, low mTOR, with an excellent result. I think mTOR used in a proper way, are a great drug. If we want to use mTOR high doses from the beginning, we have problems. Problems with side effects and different kind of problems. But if you use it in proper way, in low doses, in low CNI, I think the drug is excellent. And I want to tell you, I made a comment at the presentation at 2 o'clock. I think the drug is better than MMF or better than MPA. Better in 2 points. First, it's a stronger immunosuppressive drug, clear, stronger than MMF or stronger than MPA. And second, low incidence of cancer, low incidence of viral infection. So the proper and individualized use of mTOR with low CNI, I think could be absolutely helpful to improve long-term results. We are using now in most of our patients this day, low TAC, low everolimus, with a very good results. Very good results. Levels from 3 to 5, 3 to 6, very good renal function. Low incidence of viral, we don't do valve-site prophylaxis. Low incidence of cancer, good control of lipid, good control of blood pressure with a good follow-up. I think the problem with mTOR is that in the past we don't know how to use the drug. We use the drug as a rescue drug, and we use the drug in a very high toxic doses. I think that was the problem of the drugs. But the drug, using in proper way, I think are absolutely excellent.
Last question.
Excuse me, the last question was there. Yes, please.
In combination with the multi-units or without multi?
Without. Combination with low CNI. Low CNI, low mTOR inhibitors.
Do you use induction therapy in delete graft cases? And which type and which dose?
In which kind of transplant?
Delete graft function.
Sure, as I mentioned, when we use induction therapy, there are two advantages. One is to prevent active rejection, to prevent immunological damage, and second, in marginal donors, try to decrease CNI and try to delay the introduction of CNI. So in marginal donors, we use induction to minimize CNI and to avoid DGF and to avoid CNI toxicity. That's the two options. We don't need only to use induction to prevent rejection. Also, when we use induction, we need to modulate immunosuppressive therapy to take the advantage of this strong therapy on the prevention of immunological damage.
Okay, thank you very much.
There is one question there for 10 minutes, maybe we can answer it. There is one question there for 10 minutes.
Insist,
Apologize to the chairperson.
I got actually 2 short, simple questions.
Very short, because then we do it.
The data of OBELS about 15 years emphasizing that acute rejection correlated with the long-term survival, and we already succeed in the acute rejection. How can you explain the controversy of this? Because this is a strong data. The second thing, you advocate for protocol biopsy. Do we have any literature data to compare doing a protocol biopsy for a group of patients, normal, and strict control, even following by serum creatinine, and not waiting for creatinine 1.2 to be 1.4, if it's 1.3, I will strictly, do we have such data? Otherwise we could jeopardize our patient to protocol biopsy without any evidence.
Let me try to answer the second question. Don't jeopardize your patients doing protocol biopsies. We start protocol biopsies 5 years ago. We do 98% of our patients. We do a protocol biopsies. All of them are actually happy with protocol biopsies. If we don't do a protocol biopsies, they come to the physician and say, oh, why you don't do a protocol biopsy to my kidney? All my colleagues, all the patients at the same time are doing a protocol biopsy. Protocol biopsies take 6 hours in the hospital. We don't do it inpatient, we do it in outpatient department and give a critical information. How is the graft? How is fibrosis? How is infiltrate? How is the glomerulus? Give a very important information. I am sure that there is no studies comparing general practice with protocol biopsies, and probably never will be. But I strongly recommend to do protocol biopsies. I don't accept that they jeopardize a patient. If you do a good job in 6 hours, it's not very hard for them, and give a very important and strong information. Maybe in the future, with different biomarkers, we have the option. But I think that today, that we don't have good biomarkers, protocol biopsies give you safe and give you arguments to change immunosuppression, to increase CNI, to do different changes. So I strongly recommend to do protocol biopsies. Acute rejection, I accept it. We control acute rejection, but there are other problems. Other problems is the age of the donors are older and older, the quality of our residents are worse and worse, more diabetic, more cardiovascular, more cancer. I think that's the reason why we don't observe a significant improvement in the last 10 years on graft survival and on patient survival, although we control acute rejection. I think that's the explanation. Thank you very much, Sorry. Ladies always says preference.
I'm going to ask a very short question. Actually, this is the question that has been asked by Professor Tariq Abbas, and I just want the answer to be yes or no. Okay?
Sure.
So, if you have...
We're very clear.
Very well. If you have the means to give induction therapy with polyclonal agent at a low dose, would you recommend or would you prefer to do that for all your patients? All your patients?
That's very difficult.
To use a small dose from polyclonal agents?
I can tell you very simple. If your manager, the dean of the university, your manager allows you to use polyclonal and you use low doses of polyclonal, I recommend to use polyclonal in all the patients.
Thank you.
Very low doses, maybe 2 doses only. And then low CNI and low Hector. Low doses. I think in low doses, that's not very expensive, and give you quite good opportunity. But in low doses,
Thank you very much. We are short of time, and thank you very much, Professor Jordan.